Well, welcome everybody to Optometric Education Consultants National Webinar Series, Tuesday night edition. We're coming to the end of 2024, and it's our great opportunity and pleasure to have Dr. Rich Madonna, who's a professor and office director of continuing professional education at SUNY College of Optometry. He's the immediate past chair of the Department of Clinical Education and formerly chief of the ocular disease and special testing at the college. Clinically, his practice at the University Eye Center is limited to glaucoma patients only. He lectures nationally and internationally on glaucoma and ophthalmic imaging. He's had many positions in his career. He's been the executive board of the Optometric Glaucoma Society and is one of ASCO's representatives to COPE Governing Council. He's got numerous awards. He most recently got the American Academy of Optometry's Vince Ellebrock Clinician Educator Award and the New York State Optometric Association Educator of the Year Award. He's one of the foremost minds in glaucoma. He's a great educator, a fantastic human being, a great friend, and we're really lucky to have him. So please, Rich, take it away. You're getting your virtual round of applause.
Thank you very much, Joe and Greg, and thank you for inviting me. I hope the sound is good. Greg made a comment before about answering questions, and I hope to answer some, but I have a feeling we're also going to raise a few other questions as we go forward, because this is really a fertile area right now. So again, thanks, guys. I really appreciate it. You guys are doing an unbelievable job in educating optometrists and making it very easy for people to not only get educational credits, but to get quality educational credits. So thank you so much. And the organization that you guys have, people they probably do see it on their end, but I certainly see it on my end, and it's really just fantastic. So thank you, guys, and thank you to Vanessa as well, who I've known Vanessa for a while also. So I think we should jump right in, as it's, at least on my end, it's late. So again, we want to talk about systemic diseases and glaucoma. Let's make sure I can go forward. If I click in this box, that should make us go. So those are disclosures over the last 2 years, but all of these relevant relationships have been mitigated, and it should have really nothing to do with this discussion today. I think we've all heard this particular statement. I know I did when I was being trained. It's attributed to Felix Lagrange. It's over 100 years old. A glaucomatous eye is a sick eye in a sick body. And I think there's a tremendous amount of truth to that. Even 100 years ago, it was recognized that, of course, we couldn't look at the eye just as an organ in and of itself, but as part of the body. And Dr. Lagrange certainly realized that many glaucoma patients also were not healthy, and probably vice versa as well. So that's really the underlying theme for this particular discussion today, that we can't look at an eye with glaucoma, or probably better said, a person with glaucoma, and not recognize that there are often, and maybe always, even if we can't detect it, there's often some underlying condition that makes the person more apt to get glaucoma or to get more progressive glaucoma. So really what we're going to talk about is, what role do systemic diseases play in the pathogenesis of glaucoma? And for a little background, we should start here. Now, all of us in our training discussed what type of condition is glaucoma? What causes glaucoma damage? And there have been two main theories over the years, of course. The vascular theory of glaucoma, which talks about a reduction in blood supply to the optic nerve, and that's really based upon ischemia. The other major theory has been that high pressure causes mechanical trauma to the axons in the optic nerve. So this is the mechanical theory of glaucoma. And like many things, when there are two somewhat competing theories, usually both of them are right. And I think that's true for glaucoma. I think there's a vascular component and a mechanical component that may interplay with each other. But as the last few years have gone forward, we've come to recognize that glaucoma has other attributes. For instance, there's overlap with certain neurodegenerative diseases like Alzheimer's disease. Glaucoma may have an autoimmune component. And we'll touch briefly on that one because it's really very active right now and it's tough to really pin down what's going on there. And finally, glaucoma is clearly a genetic disease. So we'll touch on that as well. So let's jump right in. And here's polling question number 1.
All right, it is launched. What describes your use of blood pressure measurement in the office? I take blood pressure as part of every comprehensive eye exam. I take blood pressure only on older patients. Might be a little bit controversial, Rich. You might have to define older patient. I take blood pressure when I suspect hypertensive retin changes.
I used to define it a lot differently, I'll tell you that.
And I never take a blood pressure on my patients. So,
You know, Rich, you've actually already got a number of pre-questions in the chat, but I think we're going to hold off on those because I'm reading them right now, and they're good questions, and I think you're about to probably touch on it. So I'm going to hold off on the questions.
I'll let you guys kind of moderate those if that's okay.
That is absolutely fine. It's what we do.
So I'll be interested in seeing the results on this one because I think, you know, in my experience in optometric offices, it's really all over the place and it's often based upon how you practice, where you practice. But I think hopefully maybe we'll get a few more people thinking about taking blood pressures.
So with that being said, I take blood pressure as part of every comprehensive exam, 27%. I take blood pressure patients only on older patients, 2%. I take blood pressure when I suspect hypertensive retinal changes. That's your majority. That's your winner at 39%. And we have 34 that never take a blood pressure on their patients.
Yeah, and that's probably pretty consistent when we ask this question and under forums. I think just from the standpoint of public health, it may behoove us to try to take blood pressures just to uncover that person who never knew they had high blood pressure because they never go to a doctor. So, you know, if we think about it, and we're going to start off by talking about blood pressure, and it's probably going to be the largest section of my talk tonight because, as we know, according to the CDC, approximately 48% of the adults in the United States age 18 and older have high blood pressure. That's about 120 million people. So as you see here, let me turn on my laser pointer. You know, as you see here at around age 60 and older, 70% of people have high blood pressure. But even at younger age groups, lots of people have high blood pressure. So just from the public health standpoint, I think taking blood pressure is useful. But of course, what we want to talk about tonight is hypertension, or just blood pressure in general, and you'll see what I mean when I say that in a few moments, how that affects glaucoma and glaucoma risk. So let's jump into that. There are many, many, many studies that have shown a relationship between hypertension and glaucoma. I've just picked 2 of them, but they all say about the same thing. In the OSIFA study, you can see the odds ratio of glaucoma for systolic, diastolic, and mean arterial blood pressure. And they're all somewhat similar that for every 10 millimeter increase in blood pressure, there's a 1 to 3% increase in risk of glaucoma. So if you compare 2 people and 30 millimeters difference in blood pressure, that would increase the risk by 9% if you're looking at systolic blood pressure. In the Bay meta-analysis, we see that patients with hypertension had an approximately 1.2-fold higher risk of developing glaucoma than those without hypertension. Moving forward, and that's very similar. I should back up for a second. That's very similar to an odds ratio of 1.25, which means a 25% increase in glaucoma in patients with high blood pressure, similar to a 1.2-fold higher. This is a paper I'll show you a couple of times. It's getting older now, but I think it still is an important one. It's done at the University of Michigan. The two main players are Paula Newman-Casey, who actually spoke at the Academy of Optometry this year, and Josh Stein. And they do epidemiological studies. They're both glaucoma specialists. And what they do is they look at insurance data. So they have millions of diagnoses to look at. And these are self-identified types of things. They're really based upon actually insurance claims. So there's probably some slop in the data. But when you have 2.5 million people that you're getting data from, I think a lot of that slop falls out. And if you look here at the adjusted hazard ratios, you can see that for people who had hypertension alone, this was actually a paper looking at the metabolic syndrome. But for those that had hypertension alone, they had a 17% increase in having glaucoma, very similar to the approximately 20% or so we saw in the last two studies. So it appears that having hypertension increases your risk of developing glaucoma. Why might that be? Well, hypertension certainly causes arteriolosclerotic damage to the vessels feeding the optic nerve. That's what the vascular theory of glaucoma is. It may be because of ciliary body perfusion or increased ciliary body perfusion, which causes increased aqueous production. Now, that may be a very, very small amount of this, because you may remember that the ciliary body has what's called autoregulation. So unless there's a real large increase in perfusion to the ciliary body, it probably will not affect aqueous production, but we put it in there. Now, episcleral venous pressure is important. If you remember, the episcleral veins are the end portion of the trabecular outflow system. And if the episcleral venous pressure goes up, then trabecular outflow will go down because of increased resistance. And what you see on the slide is the so-called Goldman equation, and the plus P is the episcleral venous pressure. So the episcleral venous pressure plays a very big role in intraocular pressure. And in fact, it's the reason you can't lower the intraocular pressure via medications or any trabecular outflow procedure below. You can't lower it below the episcleral venous pressure. And that's why you need things like trabeculectomies and so forth. But I think the biggest reason that hypertension is a risk factor for glaucoma is not the hypertension itself, although it does play a role. It's the association with low blood pressure, hypotension. And that's because of just taking blood pressure medications, which lower your blood pressure, low blood pressure during the nighttime period, nocturnal hypotension, and so-called dysautoregulation, the lack of this autoregulation that I was just alluding to. And we'll talk about that more going forward. So let's just look at this a little bit more. So what about intraocular pressure and systemic hypertension? I just wanted to address that because if you're like me, many, many patients over the course of my career have said to me, Doc, okay, you're telling me I have high eye pressure. Is that because I have high blood pressure? And the answer is a wee bit, but it's obviously not the main reason. So in this study in the British Journal of Ophthalmology, you can see that there was a 0.21 millimeter increase in IOP for every 10 millimeter increase in systolic blood pressure, and a 0.43 millimeter increase in IOP per 10 millimeter increase in diastolic. So if the diastolic goes up 25 points, you'll get a 1 millimeter increase in intraocular pressure. Not insignificant, but certainly not the main reason why people develop high intraocular pressure in glaucoma. So this is what I really want to spend time talking about. So just to go back to some of your basic science in your ocular anatomy, you may remember that the major blood supply to the optic nerve is via the short posterior ciliary arteries. So they're feeding optic nerve head, lamina cribrosa, and even the postlaminar optic nerve. And there are contributions from the central retinal artery circulation and the pial blood vessels coming from the meninges. but the main circulation is via the short posterior ciliary arteries, often in a configuration of a circle around the optic nerve called the circle of Zinn-Haller. And so perfusion through these short posterior ciliary arteries is extremely important for maintaining optic nerve head health. And you know, in the condition called non-autoritic ischemic optic neuropathy, that this is a perfusion problem, usually an acute perfusion problem of the short posterior ciliary arteries. But here we're going to talk more about a chronic problem that we see in glaucoma, similar to NAION, but now a chronic perfusion problem to the nerve head. And if we look at ocular perfusion pressure, which we see up at the top here, OPP, has been defined as a very simple equation of the blood pressure minus the intraocular pressure. Now, I can tell you that this is a very, very complex physiological situation at the optic nerve head. But this very simple equation, and we'll see in a few moments some of the data surrounding it, this very simple equation allows us to kind of categorize what's going on at the level of the perfusion to the optic nerve. So we have mean arterial blood pressure, which would be MOP, or mean ocular perfusion pressure, which would be the mean arterial blood pressure minus the IOP, or the diastolic or the systolic. And it's usually the diastolic that has been looked at in many studies. But we also have to remember something else regarding the blood supply to the optic nerve, and that is the blood supply to the optic nerve is auto-regulated. Auto-regulation is a property of many tissues in the body, but it's a particularly strong property of the optic nerve and other parts of the eye, the brain, the heart, the kidneys, the most important organs. And essentially what occurs in autoregulation is that the tissue does exactly what the word seems to imply. It has the ability to make changes so that if it senses that the perfusion has gone down, it could raise it up, and vice versa. The problem is that autoregulation only works over a relatively narrow range of perfusion pressures. So if the perfusion pressure gets too low or too high, autoregulation may not work properly. Additionally, and we'll talk about these in a few moments, additionally, some people have either congenital or acquired dysautoregulation, meaning that the autoregulatory system doesn't work the way it's supposed to work. One of these conditions, which over the years has been called dysautoregulation, now has a different name. It's called Flammer syndrome, named after Joseph Flammer. I first heard of Dr. Flammer when I was really getting interested in this stuff back really more than 30 years ago. And he reported on the fact that he noticed that some of his patients with normal tension glaucoma also had other characteristics. And the one that he really reported on that really struck me was that patients with what we now call Flammer syndrome, when their hands were placed in cold water, their extremities did not warm up. In other words, their nail fold capillaries did not respond as they should, and they didn't dilate, so you didn't get that increased blood flow that we might have expected under those conditions. So now the full-blown Flammer syndrome has been reported, and you can see some of the characteristics in front of you. The cold extremities, low blood pressure. Interestingly, these patients tend to be slim and active. They tend to be type A personalities, striving and successful, as it says here, with some other characteristics like increased sensitivity to smell and tinnitus, tension and pain, strange responses to certain drugs, problem sleeping. And so these are things, particularly when you're looking at normal tensive glaucoma and particularly in thinner individuals, they may have elements of this Flammer syndrome. And it's something to consider because their risk of normal tensive glaucoma, because of dysautoregulation, really really is increased quite significantly. And if we characterize then Flammer syndrome versus metabolic syndrome, which is central obesity, hypertension, dyslipidemia, and diabetes, you can see the differences between the two: slim versus obese, hypotension versus hypertension, etc. So Flammer syndrome on the left, characterized by disturbed autoregulation and a greater propensity to normotensive glaucoma, versus the classic vascular glaucoma, or vascular theory of glaucoma, probably a better way to say that, associated with high tension glaucoma. So taking that a step further, we can look at the habitual IOP curve, and we now know, certainly through work over the last 20 years, that the highest intraocular pressure in the majority of people is during the nighttime period, particularly right before you wake up, which is right in here. And we superimpose on that, here's a diastolic blood pressure curve. We know that for the majority of people, the blood pressure is lowest during the nighttime period. And in some people, the blood pressure gets very, very low. These people are called dippers, and there are even super dippers. So if we remember that perfusion pressure to the optic nerve is based upon blood pressure minus intraocular pressure, during the nighttime period, intraocular pressure goes up, blood pressure goes down. For those susceptible people, then, the perfusion pressure is going to be quite low. And if that perfusion pressure goes below the threshold for that individual patient, and the autoregulatory system cannot take care of that, then this person is going to have lower perfusion to their optic nerve and develop glaucoma damage. And there's just the systolic portion. So that's something that you really should be keeping in mind as you think about some of your patients with glaucoma risk. And it's another reason to measure blood pressure in the office, not so much to look for high blood pressure, but to look for low blood pressure. So do we have studies that have shown that this holds true? And that's why I say that very simplistic blood pressure minus IOP actually tends to hold. So I'm going to show you 4 cross-sectional studies. They're not longitudinal studies, but they're pretty big studies. You may be familiar with some of them. The Baltimore Eye Survey from 30 years ago, and they're all going to say the same thing, that the lowest category of perfusion pressure is associated with an increased incidence of glaucoma. But I want to show you that in the Baltimore Eye Survey, these were African Americans and Caucasians. Egna Newmarked were Caucasians in Italy. The LALIS study, Los Angeles Latino Eye Study, Hispanics in Los Angeles, mostly Mexican patients, and Proyecto Ver, Hispanic patients in Arizona, all essentially showed the exact same thing. And even more remarkably, if you plot out the glaucoma prevalence on the y-axis with the diastolic perfusion pressure on the x-axis, you can see that every one of these studies had an inflection point right in here at about 50 millimeters of diastolic perfusion pressure. So that tells us that if the diastolic perfusion pressure, meaning the diastolic blood pressure minus the intraocular pressure, is less than 50, then the prevalence of glaucoma in at least those patient populations goes up significantly. Now, I recognize, of course, that intraocular pressure is under, as is blood pressure, is under circadian rhythm. But I think you get the idea that if you take blood pressure during office hours, you're certainly going to be able to identify those patients who trend toward lower blood pressures. And if you anticipate that their intraocular pressure will go up during the nighttime period and their blood pressure will go down during the nighttime period, you can probably identify some of these patients and recognize their glaucoma risk, or if they have glaucoma, recognize their increased risk of progression, or identify those patients as someone who may have poor perfusion, who's progressing despite normal intraocular pressures during office hours or seemingly controlled intraocular pressure during office hours. So I think this is important to remember, and I hope this is something that you'll think about if you haven't been. So a little bit more on hypertension. Some studies show that hypertension actually reduces risk. So not just hypotension or hypertension increasing risk, but what about hypertension reducing risk? And I'm only going to cite one study, but it's a major study. It's called the Early Manifest Glaucoma Trial. It was the study that was done in Sweden with an untreated control group in newly diagnosed glaucoma patients versus a treated control group. And this is a very busy slide that I've used for different lectures at different times, and I didn't want to tear it apart. But all you really need to look at is this box right here, which says that in persons who at baseline had a systolic blood pressure greater than 160, they actually had a 31% decrease in having newly diagnosed glaucoma. And the flip side is that if their ocular perfusion pressure was less than 125, which is actually quite high, they actually had a 42% increase in having glaucoma. So high blood pressure can also be protective, at least at some stages of the disease. Of course, if you have hypertension for long periods of time, you're going to affect the blood vessels to the optic nerve. And I got to tell you, I've been practicing for 40 years. And the early part of my career, I began to recognize that many patients with ocular hypertension also had high blood pressure. And I think the reason that we really did see that is they didn't develop glaucoma. At least one of the reasons they didn't develop glaucoma at that point in time was that their blood pressure was on the higher side, maintaining perfusion to the optic nerve. And again, that they would lose that over time once there was more damage to the vessels of the optic nerve. So probably a few of you are also thinking about this. Like with many chronic diseases, like with diabetes, for instance, fluctuation is bad. The body likes to keep things in a somewhat narrow range and maintain homeostasis. And we've seen in the last few years, and even before that, but I've just cited 4 studies here that looked at blood pressure fluctuations. So not just hypertension and hypotension, but what about fluctuation? And they're from both the ophthalmologic literature, but also the Journal of Hypertension. So repetitive and extreme dips in mean arterial pressure by high variability throughout 24 hours associated with glaucoma damage. Significant correlation with fluctuations in perfusion pressure associated with progression of field loss. Long-term variability of blood pressure may be a modifier of the association between IOP and visual field progression. Low systolic blood pressure during follow-up associated with glaucoma. That wasn't fluctuation so much, but I actually just spotted this today, so I stuck it in here. So the importance is fluctuation also matters, and that's something that we can't get at quite as readily, of course, because we can't take fluctuations, blood pressure rather, 10 times over the course of the day. So unless your patient is getting a Holter monitor done, you may not have this information at your fingertips. So to kind of finish up in this area about blood pressure, what can optometrists do to impact ocular perfusion pressure and blood pressure? Well, measuring blood pressure is the first way. If you don't measure the blood pressure, you're not going to find the hypertensives, you're not going to find the hypotensives, you're not going to get any sense of the relationship between IOP and blood pressure. I think it's important to discuss, at least with your at-risk patients who you're concerned about perfusion pressure during the nighttime period, to make sure they're not taking their blood pressure medicines at bedtime, because you'll be shocked at how many people actually do because they want to reduce side effects. It certainly would make sense to me, but those patients may really be driving their blood pressure down during the nighttime period. It gives you an opportunity to work with PCPs to ensure that the ocular perfusion pressure is taken into account, not only asking them to encourage their patients not to take their blood pressure at bedtime, but also not to have their blood pressure lowered too low. Primary care docs usually are very happy when their patient comes in with 90/60 as their blood pressure, because they're looking at catastrophic cardiovascular disease. However, they may be hurting those patients if indeed those patients have glaucoma or at glaucoma risk. And then, although we're not talking about glaucoma therapy tonight, I think you should be thinking about glaucoma therapies for these at-risk patients, or rather thinking about glaucoma therapies that work during the nighttime period, or put differently, don't use the ones that don't work during the nighttime period. And those tend to be beta blockers and alpha agonists, the sympathetic nervous system drops. Most of the others, prostaglandins, CAIs, ROCK inhibitors, SLT, and surgery, work during the nighttime period. They may not work as well as they do during the daytime period, but they work during the nighttime period. So it's important as well to remember that.
And Rich, before you go on, I want to engage you on this.
Yep.
How often do you engage with PCPs on this when you're talking, about glaucoma? Their glaucoma is getting worse. Hey, you're doing a great job with your blood pressure control. Can you do a little bit less of a great job? I mean, how do you interact with them, and what
Well,
has your reception been?
Joe, that's actually a great question, because I did not do it as well or as much as I should have. I would talk to the patient about telling them to speak with their PCP. But there have been times where either by letter or phone call, when I had a patient who I was really concerned about normal tension glaucoma, and particularly those who were progressing, where I did need to get the PCPs involved, because you could see that the patient was on, let's say, 2 or 3 blood pressure medications, and their blood pressure was quite low. So it's a really good question, Joe. And I'm, you hate to give a talk like this and not follow everything that you're saying, but I could have done a better job with that as well, because obviously it's not an easy thing to do to tell a PCP that, hey, you're actually doing too good a job. And I don't know what your experience has been in that regard, or Greg. I see Greg is there as well. So.
Well, I know that when I was lecturing to family practice residents, I brought this up and we had a discussion, and one of the people said, "Well, yeah, I mean, I can appreciate what you're saying, and I can cut back on their blood pressure control, but now I've got to deal with cerebral vascular accident and
That's
myocardial
exactly it,
infarction."
and it's a big. It clearly is an issue, but I'd like to think that there's probably a middle ground there. If somebody's walking in at 90/60, if you take them off one blood pressure medication, or at least have them take it in the morning rather than at bedtime, you should be able to find a middle ground. Again, it depends on the patient's risk as well. If the patient is really high risk for a stroke, then maybe you just have, something else is going to have to give, because we can somewhat control their intraocular pressure and slow down the progression of their glaucoma, but their stroke, as you say, could be catastrophic.
Yeah, I
Big,
was speaking with an internist. In fact, it is my own internist, and this is several years ago when they changed the requirements or the target goals for blood pressure on older patients, allowing them to live with a higher blood pressure than
Yep.
previous. And he
Yep.
was thrilled by that, and it has nothing to do with glaucoma. He said, all my patients, they take their blood pressure at night, they get up to go in the bathroom, they fall. Now we got a broken hip.
Yep. I agree with that 100%. So that works to our advantage.
being from now the second most famous city in Pennsylvania. First was Butler, where I grew up, and now Altoona, 4 miles from where the shooter was caught. I've been here for 29 years, meaning that I've become pretty good with a relationship with a lot of the primary care physicians, and I can just give guidance, probably in a little bit of, I do take blood pressures on every patient, but particularly we make sure we look at it whenever we have the glaucoma patient. We're looking for those dippers in a sense, or those low people. But it's a conversation with the PCPs really occur whenever you're seeing that progression. They're kind of maxed out. They've had the SLTs, and these patients are taking their medication at night. And it just kind of seems that that generation is all about, I'm just going to listen to what the primary care physician has said. And obviously, I don't want to be changing and practicing treating blood pressure. I guess it would be a case if I told them to shift their medicine. But the conversations have always been kind of rewarding in a sense, because they learn about that, and then it kind of spreads to the other, for them to help other people whenever they see the glaucoma patients coming in. So it's been nice that I'm just trying to avoid them taking it at 10 o'clock, 9 o'clock, take it a little bit earlier, avoid those side effects that you said, that they might get some side effects, but at least we're going to perfuse that nerve a little bit better when they're laying down, when everything's dropping. So that's probably about the best
Well said.
analogy
Yeah,
I can give you.
I agree with you 100%.
But don't be
Joe,
afraid to call.
Joe, do you have questions that are appropriate for now, or shall we go forward?
No, I think there are a couple that came in actually even before you
Yeah, you
began,
said, yeah.
and some have been answered already. But let's look at a couple. When does low OPP not matter, or does it always matter? And what systemic diseases most coincide with OPP and why?
Let's start with the first.
When does low OPP
It's
not matter?
certainly, well, I think it's going to matter most commonly when the OPP is lowest. But there's certainly, like with anything else, everyone is different. Everybody has a different threshold. Everybody has different autoregulatory abilities. Everybody has different even circles of Zinhaler, which are incomplete in some people and complete in others. So it's individualized. But I think the one thing we can safely say, as this slide indicates, that as the perfusion pressure goes down, the glaucoma incidence goes up. I mean, it's pretty clear to say that. Now,
really, there's no cutoff. There's no magic number. It's as an OPP value that we pick is probably as accurate as IOP of 21.
I couldn't agree with you more. And we're going to talk a little bit about cerebrospinal fluid pressure too, and bring that in. And that's kind of along the same lines. So, no two people are alike. And we all recognize that.
In answering that first part of that question, I learned a lot of this at OGS, and Rich, literally listening to you lecture, and I definitely at that point in time started looking at blood pressures, and really it's in the, when is it too low or when's it critical? I would say it's going to be in that patient that's just progressing, right? If you have a patient that's stable, they're not moving, visual field's fine, am I caring that their pressure's at that 50 or that ocular perfusion pressure? I care, but hey, they're stable. Let that sleeping,
right.
dog
see them more often if you're concerned.
Yeah, see them more often. But if they're progressing, you've got them maxed out. That's the concern, I guess. Someone comes in and has no optic neuropathy and they're running a 40. All right, they're running a 40. Maybe they're at risk for some other condition, but if nothing's ocularly happening, that's, to me,
yeah,
from an ocular standpoint,
I couldn't agree with you more.
Right. So,
hey, Rich, I'm not sure if you're going to touch on this, and if you are, we'll postpone it. But has COPD shown up to be a glaucoma risk?
I'm not covering it. You'd have to think, and I can't think of a single study right now. Maybe you guys can.
I cannot.
But you'd have to think that if somebody, similar to sleep apnea, for instance, that if somebody is getting less oxygen, then that might affect their optic nerve. But off the top of my head, that's a good question. I cannot think of a study that has, and somebody had to have looked at it. Somebody's had to have
I
looked
can't
at that
think
study.
I can't think of one either. And of course, if you find a positive study, I would find a negative study,
Of course.
that would not support it. Morbidly speaking, I hate to say it, I think COPD might reduce the risk of developing vision loss from glaucoma because that is,
Patients.
one of the up and coming killers. And it is associated with a shorter lifespan, whereas their glaucoma will outlive them. Question: if the CD is small and the OPP is low, are we still worried?
Well, I think Greg answered that question perfectly. It's certainly something. If I have a patient who walks in with a 90 over 60 or an 80 over 50, if they got to me, they have glaucoma risk. So there must have been something else that brought them to me. So that would be a concern. But in a general practice, if somebody comes in and they're just a regular patient with 90 over 60, I probably wouldn't be so concerned. I think Greg said it very well before.
They might be
All right.
going after that small disc of a disc at risk and a low perfusion. That's
Yeah,
where they
well,
might
okay,
be.
that could be a different issue. So then, I wouldn't be concerned about glaucoma as much as NAION. And, Joe, you can probably comment on that better than anyone.
Yeah, I mean, that's still would be a relatively uncommon thing. I would not worry about that. I would not tell a patient you can't use erectile dysfunction medicines. You can't use Ozempic. You've got to weigh all these things out. I mean, almost everything has been linked to non-arteritic ischemic neuropathy. Now, here's another interesting one, and I think we're all caught up in the questions. In a patient with suspected ocular ischemic syndrome and a 0.6 CD ratio with minimal notching and normal IOP, when do you bring it back for glaucoma testing and why?
So 0.6, what was the second part of that?
Minimal notching and normal IOP.
Oh, minimal notching tells me they got glaucoma. So I would think that they have early glaucoma. If they have the ocular ischemic syndrome, I think they've got more problems than the glaucoma. So I think that would have to be taken care of first. Carotid and cardiac studies.
I agree with you. OIS actually has a poorer 5-year survival than choroidal melanoma. These are people who are circling the drain. They truly have an ocular ischemic syndrome, and we really need to get that taken care of.
I'd be more concerned about
correction.
neovascularization of the retina or neovascularization of the iris and angle.
Mm-hmm.
Those are the worst case. Some of the worst cases I've ever seen are really advanced ocular ischemic syndrome.
And the OIS patients, they typically come. They end up with hypotony. Actually, that's one of the characteristics of it.
And actually start with low intraocular pressure in that eye as compared to the other. Yeah.
Yeah.
Interesting question.
You've got that OIS that's a plane that's lost an engine and is on fire. You've got to get that on the ground as soon as you can. You can do the catering later.
I have no follow-up to that. Okay, great questions.
Rich, and looking at your handout, you're going to be talking about calcium channel blockers?
Yeah.
Okay, because there's a question in here. Do you ever talk about PCPs removing? It's basically a
calcium let's hold on that one.
Yeah. Hopefully, so you hold on that because I think I saw.
Let's hold on the calcium channel blockers because I am going to mention it. Okay, so that catches us up. So let's look at cardiovascular disease, and we've kind of touched on it, and hypertension is certainly related to cardiovascular disease. So I'm just going to kind of pick and choose some of the conditions that are associated with cardiovascular disease. Now, again, this is from the same study I showed you before, and this is looking at dyslipoproteinemia. And if you, again, go back to look at these pieces of the metabolic syndrome, and I think on the handout, this circle's probably in the wrong place. I didn't catch it till this morning. It was down here, probably when I rejiggered the slide, I didn't move the circle. But you'll notice that the hazard ratio for these patients who have hyperlipidemia alone is actually less than 1. So in this case, this means there's a 5% reduction in risk of having glaucoma in this group. And many studies have shown that over the years, that statin drugs, probably because of their ability to regulate blood vessel functionality and also work through nitric oxide, that's really the channel that they tended to work, actually may have been associated with a reduction in risk of glaucoma. Even if you go down here, if you look at diabetes plus hypertension, there's a 48%, if you have both of those, there was a 48% increased hazard of having glaucoma. But if the patient had diabetes, hypertension, and hyperlipidemia, the risk goes down to 26% increase. And this is what I've talked about for many years, that the literature seems to support the fact that statin drugs actually reduce the risk of glaucoma. And so the question would always arise, well, should patients be on statin drugs, et cetera? And I think many of you know some of the controversies surrounding statin drugs. But this is an interesting paper that was just recently published in Ophthalmology Glaucoma. And it says statin use was associated with increased glaucoma likelihood in the overall adult, and the study was called All of Us, so that's AOU, with hyperlipidemia, in individuals with optimal or high LDL levels, and in old individuals 60 to 69. So findings suggested that statin use may be an independent risk factor for glaucoma. So this kind of muddies the water a little bit, but this is looking, specifically at patients with hyperlipidemia and not just statin use, although part of it was that the statin use did appear to be an independent risk factor. So again, what I've been saying for years is it appears that statins have lowered the risk of glaucoma. Now we've got this out of a epidemiological study done on the West Coast that seems to cast some doubt here. And if we look at this one, another one from 2024, which looked at, and this comes out of Korea, you can see that they looked at individual statins and looked at the risk of glaucoma, and you can really see that all of the statin drugs increased the risk of glaucoma. Although only 3 were statistically significant. Crestor, which is the first one, Zocor, which is this one has been off the market for 20 years, and Pravastatin, which is Pravachol, all had a statistically significant increased risk. Those patients had an increased statistically significant risk of having glaucoma. So I guess the jury may be somewhat out here regarding the relationship of statin drugs and glaucoma. And of course, we have to always remember that, the patient populations are different. The amount of exercise they get is different. The care that they are getting is different. The other diseases that they have are different. But at this point in time, I think it's very difficult to say what the true relationship is between statin drugs and the development of glaucoma. What I think about, though, is if someone's on a statin drug, they do have an increased risk of cardiovascular disease, which I think is something that has to be taken into account. What about vasospasm? Well, we've really talked about this already, because vasospasm is really vascular dysregulation, and we've talked about the Flammer syndrome. And for long periods of time, migraine has been thought to be associated with normal tension glaucoma, although the literature actually didn't show it as clearly as we might have thought. But this is a glaucoma talk, and I'll point out to you some of the things that are in the glaucoma literature. The collaborative normal tension glaucoma study clearly showed a higher rate of progression in female migraineurs, and that's over 20 years ago. And a recent study out of Korea showed that that migraine was a significant risk factor for open-angle glaucoma in a Korean population. And they added the presence of aura didn't matter. So I think clearly, certainly in patients who are at risk of normal tension glaucoma, certainly in females, and the third part of that in the collaborative normal tension glaucoma study were those with transhemorrhages, were at higher risk of developing glaucoma and having progression of glaucoma. So I think vasospasm is clearly important. Which brings us to calcium channel blockers, actually. Calcium channel blockers they treat hypertension and cardiac disease, as I think most of us know. And I think both Joe and Greg probably remember that 20 years ago, calcium channel blockers were really being thought of as a treatment for glaucoma because they lower intraocular pressure, not a lot, but they lower intraocular pressure. They reduced blood pressure, which sounded like a good thing, and they were potentially neuroprotective. So back in the early 2000s, it was starting to look like calcium channel blockers may be this wonderful treatment, either both topically or systemically, may be this wonderful treatment for glaucoma. But over the last few years, culminating in this very nice study done in Europe, the European Eye Epidemiology Consortium, which is really cut across, I forget how many countries, but a number of countries in Europe, clearly showed in this large epidemiological study that calcium channel blockers are associated with a higher glaucoma prevalence, both selective calcium channel blockers, which are most of the ones that we know. They have an odds ratio increasing of 1.22, a 22% increase glaucoma prevalence on patients on those calcium channel blockers. And there's a misprint here. One of these should say non-selective. That should be the first one. Apologize for that. The bottom line is on this that calcium channel blockers now are associated with a higher glaucoma prevalence. It's not exactly clear why that's so. But the bottom line is that I think there is really strong evidence here that calcium channel blockers actually increase the risk of glaucoma prevalence, even though they do have these effects on blood vessels and on the heart. So Greg, this might be a time to ask you about your thoughts because you were heading toward it before.
Yeah, it was just came in from a question that rolled in. Do you basically talk to the primary care doc to stop calcium channel blockers?
Yeah, so again, 20 years ago we would have said just the opposite, but I think there really is plenty of evidence over the last 15 or so years, and this was just a beautiful epidemiological study that really showed this. But again, I think it goes back to our discussion before of what's the most important for this particular patient. And if lowering the blood pressure is important and other medications aren't effective, then we may be left with this to reduce the risk of catastrophic cardiovascular disease. And I think this type of discussion really speaks to the fact that although in a talk like this, we can separate out many of these conditions, the bottom line is in an individual patient, they are really interactive. Yeah, go ahead.
So let me just throw out this to the audience because, I've been able to digest these by going to OGS, listen to Rich's lectures over the years. I think we have to look at glaucoma. If a patient came in and they had a pressure of 40 and their nerve is dying and they're on a calcium channel blocker, I probably want to get the pressure down rather than talking to the PCP about the calcium channel blocker. So when there's all these associations, this is a great lecture, but then you have to kind of sit back and go, okay, a patient came in, they had a pressure of say now 28, they weren't treated, we lowered their intraocular pressure, things are stable, and they're on a calcium channel blocker. Am I going to be concerned about that? Yes, I might follow them closer, but it's these patients that just keep progressing that you might then have these, okay, maybe it would be better. I got them on 3 medications. I have an SLT. Their pressure is low. This could be a contributing factor. Then that's when the discussion kind
Yeah,
of opens up.
I agree with you. I agree with you 100%. I think these things are important also because they give us some insight into what this disease glaucoma really is. And that may be more important for people in the laboratory at this point in time, but I still think it's important. I mean, I couldn't agree with you more. If somebody walks in with a pressure of 40, I'm not worried about their calcium channel blocker, that's for sure. But somebody who has early glaucoma or glaucoma risk, I'm going to be much more finely attuned to that. But again, I think it's also important to recognize the interplay of all of these things and to look for insight into the disease and perhaps other opportunities for therapeutic intervention, if not today, then down the road. And I think that's important for us as physicians to be aware of these things, even if it doesn't affect us right now on a day-to-day basis.
Hey, Rich, the question came in, do calcium channel blocker studies maybe not link the connection to the underlying systemic disease? And maybe that they are safe?
Say that one more time, Joe. I'm sorry.
The question was, do calcium channel blocker studies maybe not link the connection to underlying systemic disease, or maybe it's the disease itself?
I think that's probably true for most of these things we're talking
Yeah.
about,
Mhm.
that the disease itself may be part of it. Absolutely. Yeah, I think that's true. Now there's some laboratory evidence of what the calcium channel blockers may be doing to cause the increased risk, which may be based upon the calcium channel blocker themselves and not the disease. But I think that's a great point, and that may be true for everything that we talk about tonight. Yeah, yeah, that's a very, very good point.
We're good.
All right, so let's move to smoking. And when you look at the smoking literature, it's almost laughable because if you go back over the years, many studies didn't really show a great link between smoking and glaucoma. Even though it's obvious smoking should not be a good thing for something that is, for a structure like the optic nerve that is really based, its health is based upon its circulation. But actually, if you think about it, nicotine liberates nitric oxide. And we know that nitric oxide improves blood supply to the optic nerve. It's a vasodilator, and it affects or reduces trabecular. Did you guys lose me by any chance?
Just for a second.
Yeah, I'm gonna switch my microphone here. How's that? Can you guys hear me?
Yes.
Can you hear me well?
You're a little bit low.
How about now?
Reasonable.
Okay, let's see if we can. So I'll move on, but if you guys have some trouble with it, let me know, because I'm gonna have to play with this. But
I think you're going through your computer rather than your microphone, so check your audio.
okay. Bear with me for 1 second.
Yeah, go ahead, take a pause.
Yeah. For the audience, you guys know that I have had some issues for some reason with it's a good time for a break, I guess. But we should have this in a second. Almost there.
Joe, there's a question, and maybe I missed it. It's while Rich is doing that. It says, do CCB studies, what's C, and then down there CBB. What's CBB? Can you help us out while Rich is doing that?
Calcium channel blocker.
All right. All right.
We
So
went
Can you guys hear
through
me?
that.
Can you
We
guys hear
went
me
through
now?
that one.
much
Yeah.
better. Yep.
Yeah.
All right.
Okay. Yep. I got
Good.
kicked off my Bluetooth for a second. Okay. We're
Okay,
back.
You're good. You're
Great.
good.
So anyway, that liberates nitric oxide, and we know its effect on the blood flow to the optic nerve and its effect on the trabecular meshwork. The drug Vyzulta um, is a drug that part of it, the Bunod modification, liberates nitric oxide. But really, through the NHANES study and 3 studies actually that came out of UCSD in San Diego, all show, not surprisingly, that the intensity of smoking is associated with structural and functional changes in glaucoma, as well as changes on OCTA via reduced optic nerve vessel density. And that shouldn't be a surprise, but it's surprising that it took so long to have some decent studies that actually showed this. So don't tell your patients to smoke. I think that's probably an easy one. Okay. Let me just get my screen reset up here. Sorry about this slight delay, but I think we're good
So
there.
as you're doing that, Rich, I think so far the opening slide, when it says a glaucomatous eye is a sick eye in a sick body, I think, might be worth reminding everyone as you go through these slides and seeing all these conditions that are out there. So,
Yeah, well, you did it for me, so thank you, Greg. Here's a new one. This also comes out of UCSD. And I just got my hands on this one. But this one looked at, and you can go through all of these cardiovascular conditions, but atrial fibrillation is a very, very, I don't want to say a very common condition, but it's certainly more common than it once was. Seeing a lot of patients with AFib come in. And this one was a study that they followed glaucoma patients for 14.7 years. And essentially, they looked at this is the group over here, and then some of them developed atrial fibrillation. And they showed a statistically significant difference. It wasn't a huge difference, but a statistically significant difference in the rate. Oh, I'm sorry, these were all glaucoma patients. They showed a statistically significant difference in the rate of progression in those patients with atrial fibrillation as opposed to those who did not develop atrial fibrillation. So now another cardiovascular condition, which seems to be associated in this case with an increased progression of glaucoma. It would not surprise me if we went back and just looked at ocular hypertensives or just a general population without glaucoma. It would not surprise me if you found the same thing. So it's not really clear why this is just yet, although it likely has something to do with blood supply to the optic nerve. But the presence of atrial fibrillation now may be associated or appears to be associated with increased glaucoma progression. So something else for you to think about, if you have a patient who has AFib and you're following them for glaucoma, you may want to follow them a little more closely because their risk of progression or faster progression seems to have increased. And this is, again, this is a new study, just saw this paper fairly recently, but I think it's something else to think about as we do this. And that leads us to a polling question. And it's about the OATS study.
all right, that question is now open. So basically, what did the ocular hypertension treatment study teach us about diabetes? That diabetes increases the risk of progression of ocular hypertension to glaucoma. It decreases the risk of progression of ocular hypertension to glaucoma. That diabetes increases the risk of progression of ocular hypertension to glaucoma only in patients with diabetic retinopathy, or diabetes does not affect the risk of progression of ocular hypertension to glaucoma. The polling question is open. People are responding.
Beautiful.
I always like seeing ocular hypertension treatment study talks because I always get to pick on Dick Bennett. He always claims that he was the only optometrist, but I was doing my residency at the time, and I just saw Beth Schultz out at the academy. She was one of the residents, and I got to catch up with her, and she was actually in his module, and we were discussing how we were able to get patients enrolled into that
There you
study.
go.
So he's not the only optometrist. He just
Yeah.
happened to be the.
So you guys deserve a lot of credit because this is clearly a major study, probably one that's changed the way we do things in a lot of ways, central corneal thickness and so forth.
All right, so here we go. We have A being 60%. We have B being 4%. C 21 and D 13. So they rank as A being 62, C as being 21, and then D 14, and then B as 4%.
Well, the spoiler alert here is that actually the answer is B, which is the smallest number. So let's look at that a little bit. And that's always been one of those things that have really stood out in the OATS study. So let's talk about diabetes. Isn't diabetes a risk factor for everything? I mean, my students always remember, Madonna always says, diabetes is always the answer. If you're taking an examination and diabetes is a choice and you don't really know, pick diabetes. You'll almost always be right. And diabetes appears to be a risk factor for glaucoma. Why? Well, it's probably some combination of these things. It causes widespread and localized vascular dysfunction. It's associated with oxidative damage. Maybe the diabetes medications have something to do with it. And maybe it's just because diabetics get more eye exams because of the risk of retinopathy. So that may be why we see more glaucoma in diabetics. Regardless, in almost every major epidemiological study, and there's a listed for you, diabetes is associated with an increased risk of glaucoma. If we look again at this metabolic syndrome paper out of the University of Michigan, we see that there was, if the patients had diabetes alone, they had a 35% increase in risk of having open-angle glaucoma. So a clear increase for the reasons stated. But if we go back to the OATS study, and the OATS is now more than 20 years old, and to me, really, it really changed things probably more than just about everything. It got us to buy pachymeters. It made us look carefully about which ocular hypertensives to treat. It isolated 5 major risk factors for the conversion of ocular hypertension to glaucoma in 5 years, those being listed here: central corneal thickness, intraocular pressure, pattern standard deviation, cup to disc ratio, and age. But actually, and you can't leave this data out, you just can't ignore it, that diabetes was actually associated with a 63% lower risk of progressing from ocular hypertension to glaucoma. What the heck is that all about? Now, you have to remember, in the OATS study, these are patients without retinopathy. They're self-described diabetics, but with 1,600 patients, probably it's fairly accurate as to who had diabetes and who didn't. Interesting. Oral calcium channel blockers, I just spotted this, were associated with a 25% increased risk. So there you go. So what is this diabetics without retinopathy having a lower risk of conversion of ocular hypertension to glaucoma, which is in essence progression, right? It's kind of similar to progression from mild glaucoma to moderate glaucoma in some ways, not exactly the same. And maybe this helps explain it. This again comes out of UCSD. So let's walk through what this is saying. Patients with primary open-angle glaucoma with treated type 2 diabetes, and no retinopathies, very similar to the Oates patients, except these patients actually had diagnosed glaucoma, excuse me, had significantly slower rates of retinal nerve fiber layer thinning compared to those without diagnosed diabetes. So if you had diabetes and it was treated, you had a slower rate of RNFL thinning in this particular study. And there are numerous other studies that are similar to this one that show the same thing. And what's this all about? It's about the metformin. So here's a paper recently published in Pharmacological Research. If you're interested in metformin, it does come out of Italy. It shows that metformin is like good for everything. So you can see it, anti-diabetic, it's associated with weight loss. It's helpful with endothelial dysfunction in blood vessels. It's been associated with anti-cancer, very strongly associated with anti-aging. It's good for the gut microbiome. It lowers lipid levels. And it's really been a hot topic in the anti-aging community, where many physicians who are looking, and anti-aging does not always mean just prolonging life, but actually prolonging useful life, where you are actually feeling and looking younger. And many in the anti-aging community many of these physicians are taking metformin, even though they're not diabetic, and they're taking it because of its anti-aging and other effects. And if you think about the loss of retinal nerve fiber, the loss of ganglion cell axons, even if you don't have glaucoma, loss of we lose ganglion cell axons while we've been sitting here. We've lost a few ganglion cell axons. It's a normal part of aging. So metformin may be able to slow down the loss of retinal nerve fiber, of ganglion cell axons. And essentially, if you have glaucoma and you slow down the loss of ganglion cell axons, you're slowing down glaucoma progression. So metformin, and I know there's people on here tonight who probably know a lot more than I do about this, because this has been a very hot topic in the last few years. And if you go to any of these anti-aging talks, metformin will always come up. And maybe let me just go through the next couple, and I'd love to hear your opinion, Joe and Greg, on this. But just a couple of papers that, again, very recent papers, as I'm trying to keep up in the literature with some of this. Another one out of UCSD, metformin use associated with a thicker circumpapillary retinal nerve fiber layer, and a higher, it's really a capillary density measurement on OCTA, so more blood vessels. So again, and they're recommending more longitudinal studies regarding metformin. The one on the right, I believe comes out of China, no association between metformin use and the incidence, this is incidence of open-angle glaucoma in patients with type 2 diabetes, whereas the other was looking at patients who had glaucoma. So thoughts on metformin, guys? I'll throw it to you.
Well, I can certainly take a crack at it. I'm actually heading to my anti-aging conference tomorrow out in Las Vegas. It certainly is big. It's still big. I think it plugs into that kind of insulin resistance. They're moving into more now the hormones and the peptides, and using and metformin that's out there. So it definitely is a hot topic in the anti-aging for all the things that you mentioned, Rich. But then, there's a whole wide space. Again, if you ever been out to Vision Expo West, it's in the same exact area, same exact size as the exhibit hall, full of all anti-aging. But yeah, you are correct. Metformin, it's been talked about for a while. Now they're just moving on to other types of peptides and the injections, kind of the GP1 inhibitors that are out there, and usage with the metformin. So.
Interesting, Rich. If you go back the study on the left, from the BJL, I mean, it's saying there's an increase in structure in terms of the neurofiber layer thickness. There's an increase in the structure, capillary density, but how does how does it actually impact in glaucoma? Or I'm not sure. Is it trying to say that it is regenerating tissue?
Well,
Is it
that's a great
true
question, because I,
neuroprotective?
I don't really think it's saying that. I think it's saying that if you
Hmm.
compare patients on metformin versus
Yeah.
those without, the metformin patients would have a thicker retinal nerve
Hmm.
fiber layer.
Hmm.
That being said, I think that that's something that we're starting to see now in glaucoma, and maybe something that could be added to this talk at some time, is actually regenerating, or at least that's really what
Protecting.
neuroprotection is all about. And we're still in
Hmm.
that space where we have no neuroprotective agents, but perhaps we'll develop some. And I think it gets into we're not talking about that tonight, but
Hmm.
it gets into mitochondrial function, and the effect of reduction in mitochondrial function and leading to apoptosis, which is what we see in glaucoma, and trying to reverse that process. And probably at this anti-aging conference, I would suspect there's going to be talk about mitochondria, a lot of talk about mitochondria as you go
You nailed it,
forward.
Rich. It's all about the mitochondria when it comes to anti-aging and
Gotta
at
love
this
them. Gotta
conference.
love the mitochondria. Yeah. So
Yeah,
I
the key with the mitochondria, though, is that the kickback is that, remember, they produce 90% of the energy, and you want to keep them alive, but it's not a clean process. It also produces 90% of the free radicals.
yeah,
So
and the
then that's where it
oxidative
all comes into
species.
balance and everything out. So
And that's where the statins may come in to act as a free radical scavenger. But again, that's why all of this stuff is overlapping. But as I say, I think it's important to, although it's not on an individual patient basis, it may not help you, but I think this overview of the things that affect glaucoma is important as a physician dealing with glaucoma. I've always felt that, knowing the systemic status of my patients has really been useful to me as I take care of them. And the new kids on the block, the GLP-1 drugs, they've been shown to be associated with a significantly lower incidence of primary open-angle glaucoma, um, ocular hypertension, and the need for treatments compared to metformin. So these are the drugs like Mounjaro, Ozempic, Wegovy, and so forth. And this has been published in a few different places. This isn't the only paper to show this, that GLP-1 receptor agonists um, do seem to lower the risk of glaucoma. Why? Not 100% sure. The other group of drugs that are newer drugs associated with glaucoma, the SGLT2 inhibitors, the sodium glucose transporter inhibitors. I always have trouble remembering some of the names. There's a Jardiance, Forxiga, so these get a lot of TV commercials as well. They also seem to be associated with a reduction in glaucoma. Perhaps not at the level of the GLP-1s. So these classes of medications, which are becoming more and more popular, seem to be associated with a reduction in risk of glaucoma. Now, whether this is from their effects on diabetes or weight loss and vascular function, we just don't know. But I think there's fairly strong evidence here to say that these drugs do significantly reduce risk. So it's exciting to recognize this. And these are out of some big places. Ike Ahmed on the paper on the left, David Friedman on the paper on the right, big players.
Interesting. If you just say one quick comment, the GLP-1 medicines are reducing the incidence of glaucoma, but curiously enough, they've been associated with an increased risk of non-arteritic anterior
Yes.
ischemic optic neuropathy.
So that makes you think that it's not perfusion to the optic nerve, but it's something else. Would you agree, Joe?
Probably.
Yeah.
I,
Yeah.
I, would-
So
I would agree that we just don't know. It's just it's too soon to tell.
yeah. Yeah. So, we're in that phase of associations right now, and then let's see what happens if we can actually utilize this in clinical care. Okay, so we have about 5 more hours of stuff to do. So what I think I'm going to do is, spent a lot of time looking at papers, but I think I can summarize some of these areas fairly rapidly. And one area that I think can be summarized quickly, although this one always comes up, is the whole issue of obstructive sleep apnea. Now, intuitively, it seems to me that obstructive sleep apnea should be associated with glaucoma because of the um, poor perfusion to the optic nerve head. And this has been a hot topic for the last 20 years. And this paper really back in 2011 really seemed to, put an exclamation point on this, that in patients with obstructive sleep apnea syndrome, the high prevalence of was associated with a high prevalence of normal tension glaucoma. So that sounded like this was, relatively clear cut. But here is another paper from Josh Stein at the University of Michigan, over, I think, 2.5 million, over 2.25 million individuals. This is, again, insurance databases. And essentially what they said is that the hazard of open angle glaucoma was no different among persons with sleep apnea. And then you have this nice meta-analysis in the Journal of Glaucoma, which said that OSA was a risk factor for glaucoma. And then we go to this one, which said that there was a high prevalence of sleep apnea with patients with glaucoma, but no different than in a non-glaucoma matched control group. And then finally, we get this one out of the UK. And essentially, in this meta-analysis, OSA was associated with a higher risk of glaucoma. So I think this has been going back and forth for a while. As I say, my gut tells me that it should be so. But I think the big question with sleep apnea is, if I'm concerned about glaucoma, should I be sending people for sleep studies? And I would like the opinions of both Dr. Sauka and Caldwell.
Well, theoretically, yes. I mean, if you have a person, I think, who is getting worse at a statistically normal pressure or a pressure that you have felt is a safe level, I think we need to start exhausting our options and see if this is an issue. Of course, you can sometimes look at a patient and just suspect them. Sometimes they've already been diagnosed. They may not just admit it in the history. I don't know about every patient, but I think there are some patients that it behooves us to look into this.
Yeah, I think what has happened is such the awareness of sleep, or people complaining of snoring, and people that are. I think it was a hotter topic a couple of years ago. With all the awareness, pretty much everyone comes in. You start talking about, they're like, "I wear a CPAP machine. I wear a CPAP machine. A CPAP machine." Very rarely am I getting people that are not wearing a CPAP machine, but it could be something that you keep on the radar, as Joe said, if they're progressing. Every time I try and bring it up, it's like, "Oh yeah, I wear my CPAP machine every night." Okay, all right, that takes that away.
I kind of feel the same way. I do see, if you look at ODs on Facebook and some of these other groups, you see a lot of people who really just anytime they see any change in the nerve fiber layer, they're always advocating for sleep apnea testing or sleep apnea. And maybe they're right for all I know, because I certainly didn't do it on all of my patients. And I probably did pretty much what you guys did, which, if things didn't seem right, I think we're also biased because, Joe mentioned that sometimes you can look at a patient and say, they've got to have sleep apnea. The guy's got the neck that's that big. and he's falling asleep in the chair as he's talking to you, they probably have sleep apnea. But there are many people who don't look like that, who have sleep apnea, that we don't often consider it. So I do
Interestingly,
think,
Rich,
yeah.
Rich, when you said diabetes is always the answer, I've actually rolled it in. And you talk about all three of them. I've always said all the ills can be ascribed to either diabetes, sleep apnea, or migraine.
Okay, then I'm done. All right, so so we can get through some of this other stuff. Let's move forward. Oops, for some reason. There we go. That should do it. We have polling question number 3.
Yeah, I just lost them as I knew it was coming up. Here we go. Open the
You
question.
ready? You got it?
Yep, I got it.
So CSFP means cerebrospinal fluid pressure.
So which of the following patients would have the highest risk of developing glaucoma optic neuropathy? So high IOP, high cerebral spinal fluid pressure, high IOP and low, high IOP and high, and then low IOP and low CSFP. So they are rolling in as we speak. Joe, are we caught up on the questions?
We are.
Okay.
Well, some of you are already thinking we're not measuring cerebrospinal fluid pressure on our patients routinely. But I think this topic, there's a couple of reasons I think this topic is important, even though it's not something that we can bring to our offices on any kind of basis at this time. But I think, again, it gets to the etiology or the pathophysiology of glaucoma.
So
Yeah,
I'm
no, Rich,
displaying.
I have a hard enough time getting my patients to do a visual field, let alone spinal tap.
Let alone let alone get a lumbar puncture. So I'm going to guess that the most prevalent answer is B.
That is correct. 58% is B. And then A and C are pretty close, 26 with A and C is 15. And then 2% went with D.
Great. All right, so let's look at the issue. And I just want to remind you, I teach ocular anatomy at SUNY, so I like talking about this stuff. But I just want you to remember that once we get behind the lamina, the optic nerve becomes a central nervous system nerve tract. And as such, it's surrounded by the meninges, and it's influenced by the cerebrospinal fluid pressure, which leads to this. It was called the new pressure model of glaucoma, but I think it's an important one to keep in mind. And again, it's another one of these situations, and we've mentioned this 3 or 4 times, where when you have that patient where you're not sure why they've developed glaucoma or why they're progressing, these may be some of the issues, some of the things we've already talked about, and this issue may be important. So if we think of this pressure model of having the intraocular pressure, sometimes called the transcorneal pressure, because we measure it at the cornea, exerting influence on the optic nerve and lamina cribrosa from inside the eye, but behind the lamina surrounding the optic nerve, we have pressure exerted by the cerebrospinal fluid pressure. So the differential across the lamina is the IOP minus the cerebrospinal fluid pressure. And that's been called the translamina cribrosa pressure, or probably better said, the translamina cribrosa pressure differential. And those pressures are exerted on the lamina. In the normal condition, in a normal steady state, we end up with an optic nerve that's stable. But if this interplay between the two is thrown off, as we'll show in a few moments, then that is going to cause changes to the optic nerve. And of course, the other pressure on the optic nerve is blood pressure, which we've already talked about. So briefly, on the translamina cribrosa pressure differential and cerebrospinal fluid pressure? Well, we know the average IOP is 11 to 21. The average cerebrospinal fluid pressure is between, let's say, 5 and 13, somewhere in there. So we've already defined the translaminar cribrosa pressure differential, and that pressure differential is increased if the IOP is elevated or the cerebrospinal fluid pressure is reduced. In either of those conditions, that translaminar cribrosa pressure differential is increased, which causes a strain on or stress on the optic nerve, which will then cause it to cup and the laminar and scleral support tissue to modify itself. And that's what glaucomatous optic neuropathy is. So these are the situations essentially. In the middle, we have a normal situation where the IOP is slightly above the CSF pressure. But in glaucoma, the intraocular pressure may be much higher, or if the IOP is normal, the CSF pressure may be much lower, so the translaminar cribrosa pressure differential is higher. And the flip side, which of course we're not talking about tonight, is when the optic nerve is swollen, when the CSF pressure goes much higher than the intraocular pressure. So has this been studied? Well, yes, it has. And there are two major studies, one prospective and one retrospective. The prospective study was done in China, where they took patients with glaucoma and they did a lumbar puncture on them. I'm not sure how they got them to do that, but that may be a story for another time. I always like talking about this study because the first author on the study, Rujian Ren or Sylvia Ren, is an ophthalmologist from China who went through the optometry program at SUNY, a lovely woman. And she's been on some major glaucoma studies, and she graduated 5 or 6 years ago. But essentially, in the Ren study, as it says, in open glaucoma with normal IOP or normal tension glaucoma, CSF pressure is abnormally low, leading to an abnormally high translaminar cribrosa pressure difference. So think about some of your patients with normal tensive glaucoma who are progressing. It may be because they have low cerebrospinal fluid pressure. And the Berdal study done at the Mayo Clinic was a retrospective study on thousands of patients who had lumbar puncture, some of whom had glaucoma, but it showed something different. And just to summarize those two studies, we can see here that in ocular hypertension, the cerebrospinal fluid pressure tended to be higher, maintaining the translaminar cribrosa pressure differential. The other end of the spectrum, in normal tensive glaucoma, the CSF pressure tended to be lower, and therefore we got a higher translaminar cribrosa pressure differential leading to cupping. So again, I bring this up to make sure that at least you're thinking about this as a potential reason for why your patients may be doing worse, despite the fact is there's nothing you can really do about it at this point in time. There are some indirect ways to measure cerebrospinal fluid pressure, but no direct ways at this point in time. Okay, so there's a few more topics left. We're definitely not going to hit them all, but I think we can talk about a couple of these.
Hey, Rich, you were at the OGS this year, and Dr. Patel had some really cool videos. He did his on neuroretinal rim and glaucoma, and he reminded us, and when we were there, that the retina has glia cells, Mueller cells, astrocytes, but then the optic nerve doesn't. And he was showing some really cool videos of raising the pressure and watching the neuroretinal rim.
Yeah, those were fascinating.
Yeah. So just a reminder to the audience out there, when we talk about that ganglion cell, it's the longest neuron, in the retina. To get the ganglion cell starting in the macula, going through the nerve fiber layer, optic nerve, and all the way back to the lateral geniculate body. But remember, part of it is supported and part of it isn't. It's going through that nerve. So it's just a reminder that, it's the longest nerve. There's anatomy here. We're talking cerebral spinal fluid pressure. And just remember, when you get to that nerve, there's no rebar in there. So there's a lot of compression that be going on, and there's a lot of influences. So
Yeah, I think I'm glad you brought that up. And I think it's also important to recognize, we're not going to talk about this directly, that there is plenty of data that shows us that although the primary site of injury in glaucoma is the retinal ganglion cell and the retinal ganglion cell axon, that there are clearly changes along the entire visual pathway, including the chiasm, the optic tract, the LGN, the radiations, and back to the visual cortex. So that's just a story for another time, but that really gets to what you're talking about there. So let's talk about neurodegenerative diseases. And many studies have shown a relationship between glaucoma and Alzheimer's disease or Parkinson's disease or ALS. And I should probably add frontotemporal dementia, which has also been shown to be associated. So there is a relationship. Why? Well, we believe that, and your timing of bringing up astrocytes and other glial cells, excuse me, is that these cells, which are support cells, but they do more than support. And chronic inflammation, and inflammation does appear to play some role in the glaucomatous process, as it does with everything else in the body. That inflammatory response triggered by oxidative stress activates microglial cells and astrocytes. And additionally, here we go again, the oxidative stress stresses mitochondria, and therefore the high demand of the oxygen demand of the ganglion cells is not met, and that starts the apoptotic process. So we believe that at least this is partly some of the rationale for why we have this overlap between glaucoma and neurodegenerative diseases. And I love this paper. It's not something that many of you probably have a subscription to, Current Neuropharmacology, but I found it a number of years ago. It comes out of Italy, and it compares some of the changes that are seen in both glaucoma and Alzheimer's disease. And as you can see by the title, one age-related neurodegenerative disease of the brain. I'm not sure that's entirely true, but they noticed that, or they listed some of the things that were common. And, these are things that I think many of us know about, some brain dysfunction, including what we see in concussion and so forth. Buildup of amyloid, tau proteins, which are highly associated with post-concussion syndromes, altered cerebrospinal fluid turnover, low CSF pressure. Oh, that's one we just talked about. Altered intracranial pressure, the glymphatic system failure. The glymphatic system is the system that tends to work particularly while we sleep, which cleans the brain of waste. H. pylori infection, interestingly enough, which has also been shown to be associated with glaucoma, changes in the gut microbiome. I used to have it as part of this lecture, but I've taken it out. But H. pylori infection seems to be common. The optineurin gene, which was associated, 20 years ago, we were doing gene studies looking for the optineurin gene in glaucoma. And autophagy. Autophagy is, self-cleanup, self-eating of some of the waste products in the brain. So this paper showed that there are many of these defects that we see in Alzheimer's disease that are also common to glaucoma. So are they this, finger quotes coming, the same disease, or at least very similar diseases? Still not sure about that. I just brought in a few of the more recent papers that have shown that newly diagnosed glaucoma in patients aged greater than 65 was associated with a higher risk of Alzheimer's, but not vascular dementia. That was a Korean study, but published around the same time out of Sweden, showed that patients with glaucoma had all forms of dementia, or an increase in all forms of dementia. So there seems to be some overlap. A couple of 2024 patients here. On the left, a national cohort study. Persons with glaucoma had increased risks for Alzheimer's and vascular dementia and all-cause dementia. So whereas the others were looking at Alzheimer's and the association with glaucoma, this one is the association of glaucoma with Alzheimer's, looking at patients with glaucoma and their increased risk of Alzheimer's. And then on the right is a very large epidemiological study coming out of California, looking at the California Medicare population. And they showed that pseudoexfoliation was associated with an increased likelihood of vascular dementia, which makes some sense, whereas other subtypes of glaucoma were associated with a decreased likelihood of any dementia. So clearly, the jury is still out on some of this. And I don't want to, this is a very complicated paper, but if you're interested in this kind of stuff, it's got some big players on it. It's published in the Lancet and trying to tease out the glaucoma and neurodegenerative disease issue. And I'll just mention one other thing about this, because I think this is another important paper that came out of Poland. It's now, what year? 2019. And they made a very important observation. They said that neuronal damage in the CNS also affects retinal axons. So it becomes difficult to distinguish the cause of a moderate decrease in RNFL thickness. So, and I'm just going to read it because I think it says it all. This is particularly true for patients with glaucoma who have not been diagnosed with changes in the visual field, i.e. pre-parametric glaucoma patients. So it may not be possible to distinguish the cause of a mild decrease in RNFL thickness. So if we look at older patients who aren't clear-cut glaucoma, but do show a thinning of the retinal nerve fiber layer, these patients may have another neurodegenerative disease. They may have Alzheimer's disease. And so don't be so quick to treat them for glaucoma. And don't forget about looking to diagnose them with Alzheimer's disease. So I thought this paper hit it beautifully in terms of where we sit as eye care practitioners and older patients with mild thinning of the RNFL without visual field loss. So I know we have just a couple of minutes.
Yeah, I just want to hit the highlight of, I love it. I've seen it at OGS. We're talking all this kind of functional, all this kind of anti-aging. It's kind of neat. We're talking about the front of the eye, the damage that we're creating there at OGS. You're touching about, obviously, in this systemic, about some of the functional things. You talked about glymphatic, and I just kind of want to point out to the audience here that, you said it beautifully. The glymphatic system is to drain that waste out, and that's why it's important for us to sleep. We need to sleep long without breaks, waking up, to allow us to kind of get into that deep sleep, to allow those channels to open up, to drain those toxins out. Now, where does that fit in? And kind of this anti-aging, the body loves yin and yang. So we have a sympathetic system, go out and exercise your sympathetic system, but you have a parasympathetic system to allow it to recover. So we all know we have to exercise, but we can overdo exercise. We got to do it with the right amount of exercise, but we got to let that body recover. And that's the glymphatic system. And the sleeping, that's your parasympathetic system. That's your deep breathing to kind of watch that blood pressure come down. Deep breathing. Yoga could be stressful, but kind of your yogas, your meditations, and your sleep. And that's why you're seeing all that kind of being important in these neurodegenerative and even glaucoma that's out there. So it's really neat to see you talk about glymphatic. That's kind of in your recovery side of this whole 3 pillars of health: sympathetic, parasympathetic, nutrition.
Amen. No, I mean, it's 9:50, so we really can't.
Yeah. I think that's a pretty good ending spot there.
I just want to show, sorry about doing this. I know this can go by fast, but I just want to mention, this is a really cool paper, came out of Wills. It's a few years old, 2019. But if you're interested in this stuff and you want, it's like a 5-page paper. I guess it's 8 pages, 665 to 673. But it really talks about everything I just talked about. And it tries to pull it all together: mechanical dysregulation, molecular dysregulation, all of the things we've talked about tonight, save for, I think, autoimmunity. I think we hit just about all of these others, leading to death of retinal nerve fiber layers. So to summarize here, numerous systemic diseases are related to glaucoma. The relationship may be one of correlation or causality. Causality not shown for many of these conditions, but we should consider the effect of systemic disease on the development and progression of glaucoma. There's my email in case you wanted to send any questions. I'm happy to converse with you. I'm looking for stuff to do at this time of year, so please feel free. And I want to thank, I don't know if there's other questions.
So go ahead and unshare. I'll let Joe do the questions, but let me get up the other slide here. If you can unshare, and Joe, go ahead and take it.
The question came in, what is abnormal CSF pressure? I mean, if you want to handle that, or I can handle that for you,
Go ahead, Joe. That's your area, baby.
Well, the reality is, the answer is it depends. It ranges somewhere between 60 and 250 millimeters of pressure. And a new study has come out that says that should probably go up to as high as 300. So the answer is it depends. There's a very wide range of what is normal.
And that's not millimeters of mercury. That's millimeters of
water.
Water. Yeah.
Yeah. Sorry. Yeah.
Let me just say this while the conversation goes on. I want to point out that you'll see, if I see it right now, right where it says survey, the little red dot right there. If you want to start that survey, you can go right ahead and do it. And we're going to continue with the questions and comments before we wrap it up here.
No, we're good. We're good on questions here.
Well, I want to thank you guys. You make this so incredibly smooth, and the conversation is great. I really, again, enjoyed myself. And if you guys need anything from me, please let me know. And again, I want to thank everybody for taking a couple hours out of their night. I think we all have long days, but for me, this was fantastic. I had a great time. So thank you, guys.
We had a great time listening with you. I mean, your experience is second to none, and the
that means I'm older, Joe.
and the research you put into it is just fantastic. You're getting your virtual round of applause right now.
Oh, thank you.
It said one of the best lectures they've ever had.
Oh, that's great. Thanks so much. This stuff is just so interesting. I mean, I think we've pointed out more than once that it's probably not something, it's not like you're getting a talk on, new drugs to treat glaucoma that you're going to bring to your office tomorrow. Some of this stuff you may never see the light of day. But I also think it's really important to be, if you're really a well-rounded clinician, to at least be thinking about this stuff. I always found it interesting to talk to my patients about disease processes as well. I think that always kept me interested in what I was doing. Mm-hmm. So I hope everyone enjoyed themselves and have a great holiday, and however you celebrate it, and happy and healthy New Year, guys. Greatly appreciated. Can I get out of here so that I can leave?
You certainly can. Yes. And
great.
Rich, thank you very much.
I'll be asleep within 20 minutes.
Right, let me just wrap it up.
Lymphatic system going.
There, get that lymphatic system.
I got to go to surgery.
Let me just wrap it up and say this is the end of the education. Everyone, that's the questions. Thank you, Rich. Thanks.
Thank you.
This will conclude
very much,
systemic
guys.
disease.
Have a great night. Thank you, everyone.
Take care.